Boy. Today I'm Today I'm here to present my study on clinical pathological profile of lean type 2 diabetes mellitus patient. Traditionally, type 2 diabetes mellitus patients. I'm sorry, what's wrong with this? Okay, perfect. Traditionally, type 2 diabetes mellitus patients are viewed as a disease of obesity and insulin resistance. However, in India, we have increasingly encountering non-obese or lean individuals developing diabetes, a group that behaves quite differently from the classically obese diabetic phenotype. So, understanding the lean phenotype or lean diabetic subgroup is important because they have often different pathophysiology, complication patterns, and therapeutic needs. Studies from sub-Saharan and South Asian regions have suggested that 30 to 35% of type 2 diabetes mellitus patients are lean, and many of them are insulin deficient rather than insulin resistant. Our study adds regional data from Western India, aiming to improve early recognition and tailored management of this distinct phenotype. We had three key objectives during this study: to study and assess the clinical, pathological, and metabolic parameters of lean type 2 diabetes patients, to evaluate the prevalence of microvascular and macrovascular complications, and to analyze the correlation between BMI, lipid profile, and glycemic parameters. This was a cross-sectional study conducted at a tertiary hospital in Vadodara. We included 100 adults, type 2 diabetic patients with BMI below 18.5 kg by meter square. Demographic, anthropometric, and biochemical data was collected, and all were screened for retinopathy, neuropathy, and nephropathy, and cardiovascular involvement using standard clinical protocols. Our results are: the mean age was around 39 years, including younger onset diabetes. The mean BMI was found to be 17.6 plus minus 1.2 standard deviation, confirming a truly lean population. Family history of diabetes was seen in 25% of these cases. Most had normal waist to hip ratio, about 72% of them. The normal range is according to WHO, 0.9 for male and 0.85 for males, implying absence of central obesity. The mean fasting blood sugar was 152 milligram per deciliter, showing significant hyperglycemia despite a low BMI. When it came to complications, the results were striking. Retinopathy was found in 59% of these cases, neuropathy in 36% of these cases, nephropathy in 51% of these cases. Shockingly, left ventricular hypertrophy, that is a microvascular marker, was seen in only 18% of these cases. The lipid profile was relatively preserved. Only 23% had mild LDL elevation, 11% had low HDL, and 19% had high triglyceride levels, suggesting less dyslipidemia compared to the diabetic patients. So our findings highlight that lean type 2 diabetes is not a mild or a low risk form of diabetes. Despite being younger and non-obese, these patients had a high burden of microvascular complication. This supports the hypothesis that there are underlying problems in lean diabetic in insulin deficiency due to beta cell dysfunction rather than obesity-driven insulin resistance. So the possible explanation for this would be that is a delayed diagnosis leading to complication by the time of presentation, autoimmune diabetes or LADA misclassified as type 2 diabetes mellitus since autoantibody testing wasn't done in this study, genetic or monogenic diabetes variants such as MODI, and even visceral adiposity, fat distribution not captured by BMI data. So in conclusion, I would say that lean type 2 diabetes represents a distinct clinical phenotype: younger patient, insulin deficient, and non-obese. Despite favorable lipid profile, they experience frequent microvascular complication. Early recognition and regular screening are crucial. Management should focus on insulin preserving or insulin replacement strategies rather than insulin sensitizers. The clinical implications and limitations of the studies are: clinically, we must remember that we should not underestimate lean diabetic patients, and we should screen for complications early. We should include C-peptide and autoantibody testing where possible to rule out atypical forms. And redefine our diagnostic focus. BMI alone is not enough in Indian population. The limitations of this study was being a cross-sectional study. The study cannot establish causality. The small hospital-based sample and lack of control group restrict generalization of this data. And moreover, insulin and antibody testing were not done, so insulopenia is inferred but not proven. Further, multicentric study and longitudinal study should incorporate genetic, beta cell, and autoimmune markers for better classification. At the end of this presentation, I would like to add that there was this session of Dr. V.K. Abichandani before this, and he was also talking about lean diabetes, that is classified as type 5 diabetes in the recent IDF meeting, and I'm really grateful for this opportunity to present this paper in front of all of you. I'll be open for questions, please.
Now, nice presentation.
Thank you, sir.
What Dr. Abichandani said previous lecture, in your studies outcome, what is the similarity and what are the differences?
So the similarity is the young onset of this patient. The BMI that is less than 18.5 that is the diagnosis criteria. The other thing that he said, which was really important, was the history of malnutrition before prenatal, natal, and after the course, which was not done in this study. We have not taken history that how if there was birth weight, yes. So that was one thing that this study missed, and I think further studies would be really will be necessary to understand more. And I would also like to add more that we have not done in C-peptide measurements and HOMA indexes.
What will C-peptide tell you?
C-peptide will tell you if there is insulin production or the amount of insulin production.
You know type 1, type 2 and type 5.
Yes.
What is type 3 and type 4?
So type 3 and type 4 are
Type 3 is destruction of beta cell because of like mumps.
Okay.
Like, anyway, what is the main difference between type 2 diabetes, who is obese, and this in sarcopenic diabetes? So, what is thin, lean? Basically, it is a reduced muscle mass.
Yes.
What is the main difference?
So the main difference that I feel from my result is that there is microvascular changes seen in this type of patients.
That means the disease was pretty long time.
Yeah, the duration of the disease was really
10 years or so.
Yes.
Main difference is insulin, you rightly said, insulin production.
Insulin production, yes. Okay, sir.
Correct. Any of the patient, because there is insulinopenia, any of the patient develop decay?
Sir, we have not done that. We have not taken that into consideration.
Because you said type 5,
yes,
low insulin, chances of decay.
Decay, yeah. So, but I like to add that decay in this is one of the limitations of a study that
cross-sectional by history.
Yes, but the sample size, there might be patients of decay and type 1.
1 out of 100.
Yeah.
Anyway, very good study.
Thank you so much, sir. But
how do you